Ladies and gentlemen, could you please welcome to the stage your chair, Anita Arnand.
Good morning, good morning, good morning. It's very lovely to see so many of you looking so spry, because I know that, I know how these things go at the Confederation. You've probably networked yourself out of your brains last night, didn't you? But it's lovely, you're looking alert. That's very important, because it's a very important day, full of important speakers. Before we get to any of that, let me just do the Pixie of Doom announcement. You're going to hear it every morning. You'll be able to recite it with me by tomorrow. So in case there is any kind of fire, meteor strike, earthquake, there will be a tannoy announcement that will ask you very politely but firmly to leave the building. The exits are very well marked. The muster point, just to remind you, is outside Jury's Inn, in between Jury's Inn and the Pizza Express. Please stay there until you are all head counted and told to return back. And also, this is the weird thing that I have to do this year, which is turn your phones on. Make sure they're on silent. That's very important. And go to the nhsconfederation.org website / you've got to say interactivity, it should be up there, interactive, there we go. And it's more important than ever today, because not only can you evaluate the sessions, which helps us get them betterer and betterer for next year, but also on this occasion we've got a very important speaker. This is not much of an unveil, Jeremy, because everyone can see you, but yes, questions for Jeremy, you can also put them on, and hopefully, I say hopefully because my technical advisor, my 5-year-old son, is not here to help me with the iPad, but if it all works out, we'll be able to put some of those questions. So just to recap, yesterday, a lot of compelling material came our way. We started off with Rob Webster with that NHS Confederation survey, your thoughts on the service. And one statistic, I think, leapt out and would be particularly interesting for you, Jeremy, is that 85% of you thought it's about time politicians start telling the truth to the public about the NHS. What the NHS really needs, where it is. Also, Simon Stevens was talking about, and this is much picked up in the press, about prevention, obesity in particular. He got lippy, do you remember, about obesity? And the papers kind of loved that. Also, the papers have led with the special measures that much of NHS England finds itself in. So we're happy to think and talk about that today. 2 very important plenary sessions coming up where you'll be able to ask questions of some very important pivotal figures in those roles. But he also said thank you to the managers. Do you remember that? Did that give you a warm feeling? He said you were important to the service. And I've found a lot of you have come to me saying that's nice, but you haven't felt all that lovely of late, particularly after that VSM letter. Yes, so maybe that will be a question, and maybe Jeremy will address it. But yes, warnings of not much money, make do, all of that good stuff. We're going to have a really interesting conversation, I'm sure. Please put your hands together. Actually, just before I say it, every year I'm turning this into a thing. It's facts you didn't know about Jeremy Hunt. Last year it was that he presented a radio show with me. This year it was, I had you down as Zumba, but it's Lambada. It's a sort of blind date introduction. But also the most important thing, I think, these are choppy waters. I think you'll all agree for the NHS in the near future. Maybe quite appropriate then that the son of an admiral is going to be negotiating those waters. Please put your hands together and welcome the Secretary of State for Health, Jeremy Hunt.
Thank you, Anita. Well, this could almost be a dance floor. And I don't know if you, in fact, know any lambada, but this perhaps is not the moment. Good morning, ladies and gentlemen. Thank you very much indeed for inviting me this morning. I can see what you're all thinking. He hasn't got any notes. He's going to do an Ed Miliband and forget the deficit. I promise you I am going to spend a lot of time this morning talking about the financial pressures that we all face in the NHS. But the first thing I want to do is to thank you for having me back. It was a closely fought election. I am thrilled to be back. I can see from the ecstatic looks on your faces that you feel exactly the same. Sean Linton tweeted that he was strangely relieved to see me back. And I think that is perhaps the closest it gets to a compliment from the HSJ. I said when I was offered this job that it was the biggest privilege of my life. And that was why I asked the Prime Minister after the election if I could come back. I may have been helped by what I suspect was not a long queue of cabinet ministers asking for the same job. But it is an incredible privilege, and I am thrilled to be here, and I am incredibly grateful to have the chance to work with the NHS over this very, very challenging period in its history. And elections are a time when, by definition, politicians argue with each other and disagree with each other. But I think after elections, it's also important to reflect on some of the things that your opponents have said. And although I disagree with Andy Burnham on many things, I do want to pay tribute to his focus on the critical importance of integrating the health and social care systems at pace. And I think that is something we definitely need to do. And I want to particularly salute my former deputy, Norman Lamb, for his pioneering work on mental health. I think he was the first minister that we've had in the Department of Health who has made this a real focus, and it really needed that focus. And I think we made significant progress. Of course, there's lots more to do, but I want to say to Norman that he can rest assured we will build on his legacy, and he should be very proud of that legacy. And I think mental health is centre stage. And I think I also want to say a very big thank you to all of you, because we had an incredibly challenging winter. And despite all those pressures, the NHS has actually put in an absolutely remarkable performance. I mean, if you take A&E, which is the thing that was most talked about in the newspapers, yes, we didn't hit the target last year. We went down by 2.1%. But we actually have the fastest A&E turnaround in England of anywhere in the United Kingdom, faster than Scotland or Wales, but actually faster than Canada or New Zealand or any other country anywhere in the world that measures A&E on a national basis. And that is very impressive. If you look at RTT, we are doing now 1 million more operations than we were 5 years ago, every single year. And the number of people waiting 18 weeks or more has barely moved. And that too is very impressive. If you look at cancer, where 5 years ago, for all sorts of reasons, we had one of the lowest cancer survival rates in Western Europe. In that period, we are now doing cancer tests on 500,000 more people every single year. And over the course of the Parliament, we treated 700,000 more people for cancer than we did in the previous Parliament, a real step change in our cancer treatment. If you look at safety, we halved MRSA rates. We've introduced the toughest hospital inspection regime in the world, 21 hospitals in special measures, 7 turned round, all of them dramatic improvements in patient safety and care. And if you look at some key things that matter to the public, like mixed-sex wards, we've virtually eliminated those. And you take all of that together, and perhaps contrary to the impression that you would get from the press, the Commonwealth Fund voted us last year as the best healthcare system anywhere in the developed world, better than France, better than Germany, better than the United States, better than Australia. And so I think we should be proud of some real progress in the NHS under enormous pressure, and I want to thank all of you for that. And I want to ask you to do something even more important for me, which is go back to the organisations that you work in and thank all of your staff for their contribution to that success, because our commitment as a country to the NHS is absolute. We saw that in the election campaign. It's non-negotiable. It is part of our identity, and our NHS staff do our country proud, and the people of this country are incredibly grateful to each and every one of them. I think that does deserve a round of applause. Now, we have these big debates in elections, But after elections, the time for debating recedes and the time for words and actions really starts. And that's what I want to focus on this morning. But before I do that, I just want to make a comment about your leadership, echoing something that Anita said, because your leadership matters more to the NHS than any of my policies. And although I'm going to announce, I think, some important things this morning that will help you, in the end, none of it is as important as the leadership that you show. And perhaps I could make the point this way. Values-driven leadership matters in every walk of life, but it matters more in healthcare than anywhere else, because in healthcare we are dealing with life and death every single day. And that intersection between the financial, the operational, and the moral is what has driven everyone here to work in healthcare, and it's also what's driven all our staff to join the NHS. And that's the other reason why values-driven leadership matters, because we can't achieve anything without their support. And they need to know that despite all these enormous challenges, in the end they are led by people who share the same values as they have. And so that's why your leadership is so incredibly important. Let's look at those challenges. And I think we sort of have good news and bad news. If I start with the bad news, it is that we face a triple whammy of huge financial pressures because of the deficit that we know we have to tackle as a country, of the aging population that will mean we have 1 million more over 70s by 2020, and also of rising consumer expectations, the incredible excitement that people feel when they read about immunotherapy in the newspapers that gives a heart attack to me and Simon Stevens, but is very, very exciting for the country. The desire for 24/7 access to healthcare. These are expectations that we have to recognise in the NHS, but all of these adds to a massive pressure on the system. But the good news is that we have a plan, the NHS England 5-year forward view. We have a government that is backing the plan, and we have a government that is funding the plan. And I am the cabinet minister who argued inside my party that we should make a commitment to that £8 billion in our manifesto before the election. And I did so with great enthusiasm because it's a good plan. It's been put together by someone who I think we all agree is incredibly smart, and I pay tribute to Simon Stevens for his outstanding leadership of NHS England. And it's a plan that has the backing of all of you. But now that taxpayers have shown their commitment to the NHS through the government committing to that £8 billion, which is in fact now £10 billion when you add in the £2 billion in the autumn statement, the time for discussion about whether that is the right sum of money or not has passed, and we now need to focus all our attention on the very challenging other part of the deal, which is the £22 billion of efficiency savings that were also part of the plan and which the NHS has also committed to deliver. And it's really important to remember that these are not cuts. There is actually going to be more cash in real terms, at least £8 billion more going into the NHS year in, year out by 2020. But as we know, because of the trajectory of demand, that will go up by £30 billion. And so even with £8 billion, we need to find those £22 billion of efficiency savings. And that is really what I want to focus my thoughts on this morning, because I think that is going to be a very, very big challenge, but one that we need to give a huge amount of attention to. And so before we talk about the detail of how we approach that, I want to reflect for a moment on our approach to it. And I want to show you, here we are. I want to show you a slide which is something that Gary Kaplan, the chief executive of Virginia Mason Hospital in Seattle, says. The path to lower cost is the same as the path to safer care. Now, many of you will remember last year that I talked about the experience of Virginia Mason in Seattle, and you will remember that this is a hospital the size of a DGH in the UK that killed a lady called Mary McClinton in 2004 because by accident they injected antiseptic fluid into her brain because it was sitting in a container, which was the normal place that the right fluid was sitting, but it was actually the wrong fluid and it was the same color, and that was injected, and she had an agonizing death that lasted over 2 weeks. And while that was happening, Gary Kaplan, the inspirational leader of Virginia Mason, took the very brave decision to email all the staff in the hospital to tell them what had happened, to try and make sure that they never repeated the same mistake. And he knew that they would take a huge reputational hit if they did that. And sure enough, it was in all the papers in Seattle, massive damage to the hospital and their reputation. But that really started their journey to becoming what is widely thought to be the safest hospital in the world. And many people in this room have been to Virginia Mason, and many of us have learned of some of the things they've done by adopting the Toyota lean manufacturing techniques, not just in secondary care, but in primary care as well. And it's always inspirational to visit them and to learn from Gary and his team. But what is really interesting is at the same time as they've done that journey, what's happened to their costs. And that hospital was in deficit at the start of this journey. They moved from persistent deficits to persistent surpluses. They had one key clinic that had been in deficit for 3 decades that moved to surplus. Their insurance premium for clinical negligence went down by 26% in 1 year. The cost of one key back procedure went down from $1,500 to $150 with better patient satisfaction and better clinical outcomes. That's why he says the path to lower cost is the same as the path to safer care. And he reckons that his costs are now between 20 and 60% lower than his competitor hospitals in Seattle as a result of this journey that he's been on. And we see the same in this country, where David Dalton in Salford thinks that he's saving about £5 million every year because of Salford Royal's journey towards safer care. Frimley, another outstanding hospital, has consistent surpluses. And we can see it not just in the NHS, but in other industries as well, where, like the airline industry, which has halved the number of deaths through air accidents over 30 years at the same time as halving its costs. Or the car industry, that since the 1970s has reduced the number of road deaths 5 times at the same time as reducing the cost and improving the quality of new cars. Or even in government, where we can look at somewhere like the Home Office, which has seen its budget go down by 23% and at the same time seen crime fall to record low levels. Now, this is not an easy process, and I don't want to pretend it is at all easy, but it is about an approach to the elimination of waste. And the key point that Gary Kaplan is making is that this is not about 2 parallel processes where, on the one hand, we're trying to save money by eliminating waste so we can spend the money on better quality care. It is one and the same journey. And that is really the heart of the lean philosophy and what we need to adopt in the NHS in a much more widespread way. And that's why I want to have a word about mid-staffs. And actually the first thing I want to say is to pay tribute to the staff at the new county hospital in Stafford, who have done an absolutely brilliant job in turning that hospital around over the last few years in very, very challenging circumstances. But it wasn't just those staff who responded magnificently to the challenge of mid-staffs. It was each and every one of you. Because you could so easily have said at so many times since the publication of the Francis report, this is a problem that is unique to one hospital in the middle of Staffordshire, and it has nothing to do with what's happening at my organisation. But not a single person said that to me. In fact, you all said something different. You said, those problems at mid-staffs, I think we may have some of them at our place as well, and we want to do something about it. And as a result of that, we have really transformed our approach to safety and quality in the NHS. And that is a fantastic thing. But I don't want mid-staffs to be one of those regular occurrences in the NHS where we have some tragedy, then there's a public inquiry, then the government adopts the recommendations that are made, and then we move on to the next thing, whether it's a debate about deficits or out-of-hospital care or whatever it is. I want mid-staffs to be a moment of change for us where we resolve to become the safest, highest quality healthcare system anywhere in the world. It is just wrong that once a week, somewhere in the NHS in England, we put the wrong prosthesis onto someone. It is just wrong that twice a week, somewhere in the NHS in England, we operate on the wrong part of someone's body. Twice a week, somewhere in the NHS, we leave a foreign object in someone's body. And I am so proud that the NHS, because these are problems that happen all over the world, but it's the NHS in England that is asking the difficult questions about this. It's the NHS in England that's determined to blaze a trail across the world. And I want us to be the first healthcare system across the world that says we are going to adopt the standards of safety that you see in the airline industry, the nuclear industry, the oil industry. And we're going to reap the benefits, not just in terms of patient care, but also the huge benefits in terms of efficiency that Gary Kaplan talks about, Virginia Mason, and so many inspiring people in our NHS in England are now talking about as well. So, what are the things that need to be done? Well, most of these efficiencies are going to take a huge amount of effort from the people in this room. And they can't all be delivered by me or Simon Stevens or the people in the centre. But I think there are some things that we can do to help. I am very conscious of Ronald Reagan's saying, he said the 9 most dangerous words in the English language were, I'm from the government and I'm here to help. And I think it is important to have due humility about what we are able to genuinely do to help you. But I hope this week the announcements on resetting the market with respect to agency staff, the controls, yes, the controls on VSM pay and the controls on management consultancy pay will help you to control some costs in your organisation. But there are some more things that I want to talk about this morning, and let me start by talking about procurement and the costs that we can save by more efficient rostering of staff. For the last year, Lord Carter, Patrick Carter, has been doing a huge amount of work on this, and many people here today have cooperated with him in sharing data so that we can understand what the potential savings are of improving our procurement and rostering processes. And he will shortly be announcing his findings, but some of them are absolutely staggering. He found one hospital, a major hospital, which had 650 sales reps who were just targeting that hospital, with at any one time 65 sales reps on site. Now, of course, we pay for all their salaries, even though they all work for the private sector, through the prices we pay for our NHS products. And we're not very good at buying those products. So if you look at a box of syringes, one hospital in the NHS will be paying £12, another hospital will be paying £4. If you look at the cost of surgical gloves, one hospital will be paying £1.27, another hospital will be paying 50 pence for exactly the same gloves. If you look at toilet rolls, I know this sounds like a sort of mad bet with Tim Kelsey. If you bring up toilet rolls in your Confed speech, I'll buy you a pint or something. But this is actually not that. This is for real. A box of toilet rolls will cost one hospital in the NHS £66, and it will cost another hospital in the NHS £30. And of course, this is all money that could be being spent on patient care. Best practice in procurement says that you should have between 7,000 and 9,000 product lines. We have 500,000 product lines in the NHS. Best practice says price variation of 1% to 2%. We have price variation that exceeds 35% for many products, and that is wrong. And when it comes to the use of staff, Patrick Carter's done some work on how much time nurses spend on admin as compared to patient care, and he found the variation between hospitals was as much as 78 hours per annum in terms of admin time. That's more than 2 whole weeks of a full-time shift that could be being spent on patient care and patient contact, that is being spent in some hospitals on that, but isn't being spent at others. And then you look at the huge cost, nearly 500 million spent on adverse reactions that could be 10,000 nurses' salary. So what are we going to do on this? Well, I talked last year about a compact with you to try and find these efficiency savings. And our plan is that shortly, Patrick Carter will publish his plans for a model hospital, what the best practices in procurement and how we can get the best prices, as we should be as the biggest purchaser of healthcare products in the world, as our NHS is. Then by September, he will share with you a sum of money that he estimates that you could save in your trusts if you adopt these practices. And then we will spend between September and December working through that sum of money with you, so that by December it is an agreed sum of money. And then I'm afraid from January the hard bit starts, which is actually implementing that change in practice. But it'll be done on the basis of transparency of data, and I hope this will help you to release a lot of extra savings. Now the second thing that I think we can help you with is around the sharing of best practice. We have fantastic practice in our NHS. I mean, just to give some random examples, in Sheffield, the way they saved over £3 million by improving bed flow, reducing bed stay and death rates at the same time. In Cornwall, the way they reduced emergency admissions by 30% by the use of GPs. Guy's and Tommy's, the way they used an early screening process to reduce their bed length of stay from 13 days to 8 days. There is fantastic practice, world-beating practice in the NHS. We're just not very good at spreading it around the system. And one of the things that happens in nearly every other country in the world which helps diffuse best practice that we don't have in the NHS is hospital chains. So we have accepted David Dalton's recommendations as to what we could do to develop hospital chains, FT chains, in the NHS. But I want to go further and say that by September we're going to have a competition, and NHS England and Monitor will choose by September our first 4 nascent NHS FT chains. So any of you people who think you're up for being one of the first hospital chains in the NHS, now is the time to think about what your proposal is. And if you are one of the 4 people who are selected, the government and NHS England will do everything we can to remove the obstacles in your path to developing those chains, and that I think will be something that will make a major difference. A third way that we can help you is about the way we publish performance data. Bruce Keogh today has written a very important letter that points out the inconsistencies in the way we publish performance data, with A&E figures published weekly, RTT monthly, cancer quarterly. And he has said that we need to have a much more consistent approach, publish it all monthly on the same day, and also include the safety statistics in that. And that way I think we can have much more consistency in the way we report performance, and that's something that I think will also be welcomed. And then the final area where I want to support you today is recognition that improving efficiency and productivity doesn't just stop at the front door of a hospital. It's also about what happens outside the hospital. And Simon Stevens' comments yesterday about the scandal of childhood obesity are absolutely right, and I can commit that the government will be publishing a national childhood obesity strategy before the end of this year. But it's also about looking at the whole patient pathway, and it's bringing the same transparency and efficiency and accountability to the commissioning of healthcare as to the provision of healthcare. And so I have asked Chris Ham of the King's Fund to help myself and NHS England develop some transparent metrics that look at the provision of healthcare in every part of the country as the proper and correct way of holding CCGs accountable for the way they deliver healthcare. And let me show you what this might look like. So the intention here is to look at global best practice and look at the models that have been used in places like Sweden or the HEDIS system in the US, and to really move one step closer towards true outcomes-based assessments. And for that reason, the main lens through which we are going to look at the performance of healthcare economies is going to be patient-focused. So these aren't the final proposals. This is one of the things that I'm asking Chris Ham and the King's Fund to look at closely. But I want to give you a flavour of what it is that we're thinking. We're thinking that essentially we would look at the performance of CCGs, who, as you know, we hope will be responsible for all commissioning of healthcare, not just secondary care, but co-commissioning social care, co-commissioning primary care, specialist commissioning, and so on, through the lens of 5 key patient groups. And the idea is that everyone will be a patient in one of those groups. So the groups that we think broadly cover the main priority areas are older people, people over the age of 70, vulnerable older people, other people with long-term conditions, diabetes and so on, people with mental health conditions, mums and children, and then the generally healthy. And for all of those patient groups, we all know that healthcare is a combination of 3 things. It's a combination of access, getting the care you need when you need it. It's a question of quality, clinical outcomes, safety, all those very important things. And it's a question of prevention, what we do to actually stop conditions deteriorating, stop people getting conditions in the first place. Now, how you weight those different factors is of course very, very important, and that's one of the things that Chris and the King's Fund are going to be helping us to think through. And also they will be helping us to understand where we don't collect data that we need to collect data. So I think it's very important that we know about the quality of mental health provision in any town CCG, and we know whether the mental health provision is better than next door town CCG or worse than next door city CCG. That's very, very important information. Of course, it's not just going to be about the CCG, it's going to be about the mental health provider, it'll be about the service offered through GPs and so on. But in the end, the CCG holds the checkbook. So they are responsible for making it work. And if we do this, we will be truly one of the first countries in the world to try and understand the quality of whole patient care, of an entire patient pathway, primary, secondary, social care, where it's working, where it isn't working. And this will be absolutely vital information for the intervention regime that Simon talked about yesterday for underperforming health economies. Because the intention here is that we are able to leave you alone if you're getting lots of green ticks and lots of blue OKs, but on behalf of patients, we have a responsibility to step in if we have persistent failure that is not being addressed. And then we've actually got two other columns at the very end there, which you may have noticed, which are about resilience, your preparations for winter, preparations for sudden spikes in care. That's really important, the urgent and emergency care picture. And then transformation, because not all of the work you do will be work that you can see the benefit of within a 12-month horizon. Some of it is incredibly important for the next 3 to 4 years: health and social care integration, electronic health records, per patient costing, governance. And so we think it's very important that we have a transformation metric that recognizes the progress in these key areas as well, even if they're not going to be immediately apparent in terms of improved care for patients. So that is how it looks, and yes, you will be able to compare the outcomes area to area, but I want to stress this is a way, if we do this, that we can actually move beyond targets as a way of driving change in the NHS to transparency, to peer review, and to learning, becoming a true learning organisation, the world's largest learning organisation, as the real way that we drive up quality. And if we can do that, that will be transformational for the NHS, because in the end, a system like the NHS lives or dies by the quality of care that we offer. Nearly 70 years ago, Nye Bevan was standing behind the same dispatch box in the House of Commons that I stood behind this week, piloting through Parliament the bill that set up the NHS. And he didn't talk about healthcare for all. He didn't talk about universal access. The phrase he actually used was universalize the best. Universalize the best. And I think it's really important that we remember that vision. Now, we have big challenges. As a taxpayer-funded system, resources are always going to be tighter, although we avoid the cost inflation that you get in insurance-based systems. We have been very good at universalizing access, better than anywhere else, going further or faster than anywhere else in the world. We have been less good at universalizing quality, but I think we can be the first in the world to do that as well. And I think we can be for a number of reasons, but first because we are by far the most transparent healthcare system in the world. We've gone further in the NHS at publishing variations in the quality of care than anywhere else. All countries have disparities between their best hospitals and their worst hospitals. There is no country anywhere in the world that has put 10% of its hospitals into special measures in the last 2 years alone in order to deal with that discrepancy. We also have the most developed primary care network anywhere in the world, and that's why treasuring and valuing the role of GPs is going to be a very important theme of mine over the next 5 years. But part of that is that we have electronic health records in primary care, which most countries don't have, but we've gone further, and 97% of patients now have access to their own EMIS or System 1 records in primary care. That is a huge step forward. We have other advantages in the NHS. We have our huge commitment to innovation, the fact that we want to be the first country in the world to decode 100,000 genomes. And we also have the rock on which it is all built, which is the values of our amazing 1.3 million NHS staff. And that's really where I want to finish this morning. I want to come back to values-driven leadership and the importance of getting the culture right, because if we're going to do this, we have to think about the culture at the start of the process, not as a bit of seasoning at the end of making the meal. If we talk to doctors and nurses, first of all, when we're talking about how to improve quality for patients, we need to talk to them, first of all, about how to have more efficient healthcare and less waste. And we need to carry them with us on this journey. And I want to tell you a story of when I went to China with David Cameron a year and a half ago. And it was a 3-day visit. And I want to let you into a secret, which I'm sure you will keep, which is that by the 3rd day, we were in a city called Chengdu. And I'd actually had enough of visiting Chinese hospitals, and I asked if they would sneak in a visit to a temple. And I went to this temple, and I was met by a smiley, shaven-headed Buddhist monk. And I said to him, what advice would you give political leaders? And he thought for a moment, and he said, leadership by values. And I came back to the UK, and 2 days later, Nelson Mandela died. And I thought, there is the supreme example of leadership by values. And you know, in our NHS, we have so many examples of leadership by values, whether it's Tracy Fletcher, Claire Paniker, Eileen Sills. I won't ruin anyone else's career by mentioning their names, but we have incredible leadership by values in our organisation. And we should remember it isn't just the big names, it's also the people we see every day, the A&E doctor who stays with someone while they die, the GP who takes extra trouble to get to the bottom of a diagnosis that may be cancer, that may not be, the nurse who takes that extra trouble in a dementia care ward. That is leadership by values. And that is what, in the end, our entire NHS is built on. And so it's about safer care, higher quality, lower costs. It's about being patient-centred and being patient-driven. It's all those things really matter. It's about a dream that is not just universal healthcare for all. It's the best quality healthcare for all, to universalise the best. That's not just my dream. That's the dream of over 1 million people out there who've given their lives to the NHS. We mustn't let them down. Thank you.
Would you like to come have a seat and we'll have a chat? So one of the things that was very interesting that you spoke about was culture and tone, and that it's very important to have a culture, a constructive culture. And you also thanked the people here for the very tough job that they do. And yet, this letter, this VSM letter that was sent, is to many akin to a howler in Harry Potter. What is your reaction to the discomfort that has been expressed at conference this year about that?
Well, I think it's actually totally consistent with what I'm saying, because we will not succeed unless we carry our staff with us. And some of these salaries don't feel fair to the staff who work on the front line. Let me be absolutely clear. I have no problem at all with people who do an outstanding job running hospitals getting very generous rewards, getting paid more than the Prime Minister. I have absolutely no problem with that. And so if it's someone who's turned around a CQC-rated, Chief Inspector-rated hospital that's in special measures and turned it into a good or outstanding hospital, if it's someone where that salary can be justified on the basis of their track record or what they have delivered, then I will support it. But we need to be able to make that argument to staff who are working on the front line who are on much, much lower pay, and we won't carry them with us with all the very difficult changes that we're going to have to make over the coming years unless we can make that justification, and that's why I think it was important to send that signal.
Post-Francis report, you have made a cornerstone of policy, regulation transparency. That's going to drive change upwards, you say. And many of the executives that I've been speaking to, even this morning in the session, say, look, it's the regulator who tells us you need to hire in consultants to turn around your ship. It's the regulator who tells us we need to get more interim staff in at a management level, and yet we have the Secretary of State now telling us that we are being put on the naughty step for doing said hiring.
Well, first of all, I would make a distinction because I don't believe that what I have been doing over the last 2.5 years is saying that I want to drive up quality through increased regulation. I think it's through transparency that's the key. It is being done by the CQC that is also the regulator, but for me this is about transparency and peer review being the main engine of change. And I think we need to look at those examples because I do understand that sometimes people are asked to do things and the easiest and quickest way of doing it is to use a management consultancy, but I also think that management consultancy spend has got too high. So if that's change that needs to happen from the centre, then I want that to happen from the centre as much as I'm asking you to make that change on the front line.
And we're going to open it up to the paddle people. So if you see, if you want a question and you see people with paddles, please just attract them. And the paddle people, if you just wave your paddle at me, then I know that you've got a question. 85% of people saying it's about time in this NHS Confederation survey for politicians to tell the truth about the NHS. Do you know what they're talking about?
I don't actually. I think, look, we have a big national debate about the NHS. I think that accusation is unfair. I think in the election campaign we had a very big debate about the very thing that most of you were saying wasn't being addressed before, which is money. And we had in the last 6 months NHS England and all the NHS arm's length bodies putting together the forward view with costings, with the NHS's own view of what the money was that was going to be required, and then we had political parties putting forward their offer of how they were going to deliver that money. And my party said it was going to deliver the 8 billion. So I think we had a big debate. I think there are some debates that I think were unnecessary, like the big debate over privatisation, which I don't think is happening on the scale that some political parties are alleging. But I think it was a pretty full and frank debate. But I think we now need to move on from those debates to actually delivering that plan.
Now we have of course overrun, which we always do with an interesting speaker and interesting questions. So we're going to take a few questions from the floor. If you have questions, waggle your paddles. Number 6 has one, number 2 has one more, number 1 and number 3. We'll do it in that order. Number 6.
I'm Julia Cumberledge, Secretary of State. Thank you very much for that very, very interesting talk. Best ever, I think. Can I just ask you to say a little bit more about the chains, the hospital chains? I've been asked to review maternity services by Simon Stevens, and of course one of the things we've been looking at is Morecambe Bay, where you've got an isolated unit that got into deep trouble on maternity services. Do you see the chains actually picking up some of those very isolated, geographically isolated units, and how would they work? As education, where we've got chains doing schools.
I thank you, by the way, for the work you've done, not just on maternity for Simon Stevens, but over very many years, when you've been a very strong voice for improving the quality of care in maternity. I think there is clearly a pattern in some of the hospitals where we've had problems over the quality of care and the issue of geographical isolation. And whether that is because it's harder to attract people to work in those hospitals, or whether it's because they become more insular because they're a long way away. And actually in Morecambe Bay, even within the trust, there is a problem of distance between Lancaster and Furness, which is part of the issue. I think chains could help that by helping to break down that insularity and by giving people in trust that are perhaps a long way away, somewhere like King's Lynn, for example, a chance to understand the procurement processes, the rostering process that happen in much bigger hospitals, and we can spread back best practice much more quickly. And I also think that there is relevance to things like the debate over consultant-led maternity services. Sometimes in a chain, you can have flexibility by offering 24/7 services in different hospitals on different days of the week, and that's also a possibility as well.
If you don't mind keeping your questions short, we'll get 2 more, and then I think we really will be out of time. Number 2, yes.
Hello, Alistair Stewart. I'm a psychiatrist and medical manager in Oldham. Simon Stevens yesterday touched on 2 issues. One is the massive task of transformation we're looking at over the next 5 years, but also the immediate problem of the financial state of the NHS. But he skated over it, I thought. Apart from, if I remember rightly, he said there's no more money available for that. So what's going to happen about all the trusts that are currently in deficit?
Thank you.
Well, I don't think we have skated over it. That's why we made the announcement on Monday about limits on agency staff spend, which I think could save hundreds of millions of pounds potentially this year. The measures that we're taking on procurement, a lot of the things that we're talking about could start to be implemented immediately. And we do, in the autumn statement, we found an extra £2 billion for the NHS. So I think the government did recognise those real financial pressures. But we also, in the NHS, have to recognise how challenging it is for the government because of the financial pressure in the rest of the system. And, there is a limit to what we're able to do. And so I think it's now the NHS's turn to engage with making sure that we live this year within our means.
Number 1.
Hello, my name is Virginia Patania and I work in Tower Hamlets, where we recently had a very vocal campaign on the removal of the minimum practice income guarantee. My question was around the fact that your presentation doesn't mention health inequalities and deprivation, and the fact that CCGs and very deprived boroughs will essentially be picking up a co-commissioning allocation budget which has no recent evidence base around the links between deprivation and workload. So my question was, do you feel that CCG allocations adequately reflect deprivation? And how do you suggest supporting CCGs whose allocations reflect this crippling deficit?
I think that the entire presentation I just gave was about health inequalities, because my entire presentation was saying that we need to universalise the best standards of care throughout the entire country to make sure that everyone is getting the best standards of care. And the funding formulas that are now decided independently by NHS England, of course, do take account of health inequalities, and it's right that they should do so. But we have taken longer to actually get CCGs to their target allocations than we would have liked in a period where the NHS budget was effectively static in real terms, because in that situation to get people close to their budget, we would have had to give real terms cuts to other CCGs, which we didn't think was fair. We are now moving beyond that phase, so I hope we can make faster progress in the issue you raise.
Last question for me, Secretary of State. Yesterday you would have seen the ADAS report about the way in which they feel themselves to be on their knees. That it seems to be the feeling coming from those involved in social care. That is going to impact directly on all the people here and what they do. There is fear. There is fear that one side is going to collapse and lean so entirely on the other that this is going to be an unworkable model in the future. What do you say to that?
Well, that's why I think we have to move at pace towards the full integration of health and social care. I think they are absolutely right to say that what happens in the social care system has a direct impact on what happens in the NHS. And I don't think we can say that, I'm all right, Jack, and it's just going to be tough for you, because of the direct impact it has on things like A&E attendance. And, we will, of course, reflect that in our thinking when we make the spending round settlement. But the real solution to this is not to see them as two separate systems, to see them as one integrated system, and to look at health outcomes across the health and social care system, not in the silos of different systems.
Thank you all very much indeed for your questions. So thank you very much indeed for being with us today. Please put your hands together for the Secretary of State for Health. Thank you very much.